Matt, my man, how are you doing today?
We're doing great. I'm really excited for this episode, Chris.
Yeah, today's episode is going to be phenomenal. We're actually doing a roundtable with two of our past guests, Dr. P and Alexis. We're going to have them kind of duke it out on the differences of what they deal with when it comes to mental health, medication, and addiction. So it's going to be an
Well, I
interesting
wouldn't
one.
say I wouldn't say duke it out. I'm just saying I think the point of views, the
Yeah,
difference between treatment or what have you. I think it's conflicting types of treatment, so they have different points of view, so that way the audience can really kind of
yeah.
see both sides. I think it's a really exciting roundtable. It's the best one we've had thus far.
Yeah, absolutely. I'm excited for it. Like we said, Dr. P is great at what he does, and Alexis knows the recovery world in and out. And I'm excited to see how this folds.
All right. So without further ado, let's take it away.
When it comes down to benzodiazepines, really, it's one of the older medications that's been around for a very long time. And currently it's really used a lot more out of indication than for what it's indicated. So if you take anybody who's having any kind of a crisis and you typically put them on a benzodiazepine, it's going to calm them down. It's temporary. It's unfortunately incredibly effective in calming them down, but it doesn't, it tends not to really fix the problem. So, for example, if you have somebody coming in, they've got a diagnosis of PTSD, most people don't realize that benzodiazepines are actually a relative contraindicated. They're relatively contraindicated for PTSD. The reason for that is because they kind of put you in the state of almost not having to deal with reality. So you don't develop the ability to cope. And over a period of time, you build up tolerance to the benzodiazepines, and that'll certainly make it where you need higher doses. In fact, I've had patients where they're completely off the benzodiazepine, but they've done such a number on them that the only way I can get them to completely stop all benzos is to have a tiny vial of maybe like one or two tablets that they're not going to take, but are comfortable knowing that it's available. So it's pretty dangerous stuff. Really, from a psychiatric perspective, the only sort of accepted indication for benzos would be if you have someone where you're waiting for the antidepressant to kick in, or in spite of the antidepressant kicking in, you've got so much anxiety that you need something on board, just kind of temporarily there. Now, there are different types of benzos that are available, which act over different time periods. For example, Restoril, it used to be very often used for sleep. It's in the system for a very long time. Something that's a little bit shorter acting would be clonazepam, and something that's shorter than that would be, something like Xanax, and even shorter and typically more effective is Ativan. Now, the pharmacokinetics play a huge role here. So things that typically are in and out of the system quickly, something like Ativan, they tend to build up in the system much faster. And if you look at whether or not a particular drug, most drugs are able to create euphoria, it comes down to how quickly they can build up in the system.
As far
So,
as tolerance,
Well,
or when you say
no,
build up the system,
well, my mind is blown already. I mean, we didn't even get to intro the podcast, And my mind is blown because of all the medication you just listed. And I am a frequent melatonin user. So when you're talking about, diazepam and all these other ones, I was just like, I'm blown away. So,
Well, I mean,
please
it's my
continue,
bread
Doc.
and butter, man. Getting people off of those medications, it's tough because you really kind of have to explain to them how they get into the system. But going back to the question that Chris had, which is, like as far as building up tolerance, no, we're talking about pure euphoria, right? So if you have just about any medication that builds up in your system that has some effect on the brain, almost any effect, and if it builds up in your system very quickly, it tends to have euphoric effects, you know? So to kind of segue that into like Adderall, right? So Adderall is amphetamine, dextroamphetamine salts. And it's something where you take amphetamine and you attach it to different salts that break down in your stomach at a differential rate. Um, what that does, it prevents it from building up very quickly in your system, and you kind of have like a longer effect on it. It's supposed to be effective for ADHD. Now, people, they'll break down Adderall and they'll snort it. And when they do that, it actually circumvents the entire system and goes directly into your brain. And when that happens, it builds up so quickly that you get euphoria out of it. So the key to understanding euphoria from any psychotropic medication is how quickly it builds up in your system. And kind of an interesting side note with that, um, I had a friend of mine who did some research published on back when, I don't know if you guys remember, the Silk Road was a big deal in the
Oh
dark
yeah,
web.
Yeah, the
yeah,
You
dark
know,
web.
dark
so
web.
what they did was they looked at the price of the different drugs that were being available and tried to look at the pharmacokinetics, which is how quickly your body processes it and how quickly it builds up, and tried to look for factors that determined if it was more expensive or not. Across the board, any medication that builds up in your system very quickly, I'm talking, you're measuring blood levels, you're measuring CSF levels, it
Mhm.
goes from 0 to like 100, very quick. Those actually tend to demand a much higher premium because of the euphoric effects. So the reason I bring that up is because some doctors will try to take people on Ativan and Xanax, which are more likely to give a euphoric effect, and transition them to longer acting like clonazepam or, even Restoril, which tend to have longer effects and tend to build up slower in the system. It's kind of a give or take with that because when you do transition people into those type of medications, like for example, clonazepam, it stays in your system for a very long time. And in that period, if they end up, let's say, drinking alcohol or, consuming opioids, it tends to kind of add on itself versus something like Ativan or Xanax that's typically in and out of your system quick. So you're kind
Mhm.
of trading off there,
And
Um,
real quick, what's the abuse potential for the benzodiazepines that you just um, discussed? Is there, I mean, obviously there's going to be some sort of abuse potential being something that gives the reward pathway a little kick, but what is I mean, I guess not the percentage, but what do you feel is the rate of addiction when being on those?
Well, let's trail it to pharmacokinetics, right? So there are people out there who are addicted to benzos because of the euphoria, but I would argue there are just as many people out there who end up feeling indebted to benzos, essentially where the benzo is holding them hostage because they haven't had any work put into managing their anxiety. Um, there are people out there where they are not willing to wait till the antidepressant builds up in their system when you can take a benzo and it quickly takes care of you. So if you have someone who has never had, let's say, this conversation we're having, who's had nothing but benzos available to them for, let's say, 10 years, and they can't get through their day without a benzo. It could be something long acting or short acting. The question becomes, would you call that addiction, right? Because there's no euphoria there, but they are not going to be able to function without a benzo on board. Those typically tend to be the tougher cases because they need something for anxiety. And I'll tell you, nothing works quite as well as a benzo when it comes to immediately taking care of anxiety. There are some studies out there that, Buspar is comparable. But if you talk to anybody who's had exposure to benzos and, try to transition them into Buspar, it's usually an uphill battle. So to
Now
try to get,
I have a question. I didn't mean to cut you
Yeah.
off, but I have a
No, go
question.
ahead.
So back to your example about having someone, habitually taking it for 10 years, whatever. And that's fine. The question that I have for you is it because it is a habit that mentally they think that they need it, or is it and I say this because when I played sports, right? I was a creature of habit. Like I needed to have a certain thing. I needed to not get a haircut on game day. There were certain things that I needed to do in order for my mind to be, at ease to play well, right? And
Sure.
so the question I have is it the actual medication for that long, but if it's been happening for 10 years, has it just become a habit to where mentally they think they need that pill, whether it be long acting or short, that okay, I just need to pop that pill today and I can get through today because it puts my mind at ease.
So Matt, that's a good question. The
Mhm.
answer is all of the above, man. So you have to remember that some of these people, they've had panic attacks that are life altering.
Mm-hmm.
And they're willing to do whatever's necessary. This wouldn't be kind of like you're going to play a game and you just want to score a high score or you feel like you're going to have a good day. This is like, the last time, I had a car accident
Yeah,
of sorts internally.
it's
I
crippling.
was
Yeah.
my benzo, and so as long as I take my benzo,
Mm-hmm.
I'm not going to have a car accident.
Yeah.
So,
Oh,
I think medicine, unfortunately, is just as much of a culprit because we tend to try to simplify people into saying that, oh, this person is seeking that euphoria, that dopamine. But in my experience practicing, there are as many people out there who, when you really get down to it, feel like they're being held hostage,
Mm-hmm.
um, because that's the only thing they can definitively say prevents a panic attack. And you put someone on a antidepressant, it's going to take a while to kick in, and also it's going to take a while for their psychological growth to catch up to the trauma
Mhm.
that they've gone through.
At Palms Behavioral Health, we understand the journey to mental wellness. Our dedicated team offers personalized care for adolescents, adults, and seniors. We focus on individualized treatment plans, addressing a wide range of mental health needs. Our evidence-based practices and trauma-informed care ensure sensitive and effective treatment. Palms Behavioral Health, healing minds, empowering lives. Contact us today.
So, uh,
Well,
it's go ahead.
to add to your point, it's kind of like what you said. Maybe they've never truly dealt with the underlying cause of the anxiety. And so it's so much easier to take a benzo because it is so effective immediately. And then there's less motivation to like learn those other coping skills that are maybe harder or take longer to learn and adapt to and become that habit, therapy takes a while to like really dig down in and figure out where's that depression and anxiety. I mean, part of it's clinical, right? But you can also deal with it with coping skills. And so to really find that balance between medicine and holistic treatment, I think
Mm-hmm.
is what we need more of,
Mm-hmm.
because I think America has a tendency to just throw meds at it,
Yeah.
right? Everything,
Take a pill.
everything, take a
Yeah.
pill for everything.
Yeah.
So really we need to find that balance to
Agreed.
treat the
1,000%
patient.
agreed. Yeah.
I'm
Mhm.
glad you brought that up because I wanted to add on to that and have Dr. P kind of see his side of it. So just as Alexis said, there's two parts of addiction, or not even addiction, but taking care of a mental health illness. So we'll just go with benzos and anxiety. So do you suggest, and is this the best way to do it, medication along with talk therapy instead of just taking medication because you're not really digging into the actual cause? I
The
mean, does
root
that
of
kind
the
of seem
problem. Yeah.
correct?
The root of the issue. Yeah.
So, I mean, as you guys know, there's again, not to get back on my soapbox like last time, but there's a huge financial component to this.
Of course.
Mhm.
Now,
Big pharma. Yeah.
The experience that a lot of your listeners have had with psychiatry, unfortunately, is, they have been pushed through being seen every 15 minutes, right? You go in and you tell them this is what has worked before in a lot of these online type situations where they, these are the meds that work, here you go, have a good day type of deal. Um,
Mm-hmm.
it's financially, I think, tougher to make money as a provider, as a psychiatrist, if you're not moving the kind of volume
Yeah.
that a lot of these psychiatrists move. So if you really want to help someone out and make them independent, um, you cannot take care of a patient in 15 minutes, no matter what
No, agreed.
Yeah.
people say.
That
Um,
quantity over quality model, yeah, definitely.
that's
I agree
huge.
with you 1,000%, Doc.
Yeah. So when you look at people who are writing for benzos, I have these conversations with some of my patients. These people, I don't want to generalize, but if you need a patient who's going to be intact, who's not going to fall apart up until your next follow-up, and in the next follow-up, you can use 15 minutes, and that's all you can use. Anything beyond that, you're losing money. Then you know what? Benzos actually do work for that. The problem is that you're creating individuals who are dependent on the system,
Mhm.
and while they're dependent on the system, they end up building tolerance to the benzo.
Yeah.
So
Mm-hmm.
over a period of time, they'll need such a high dose to have the same effect, because the brain definitely does build up tolerance to it, that eventually they get labeled as, quote unquote, addicts. And by the time they realize it, it's too late. And these individuals are not, your stereotypical addicts, as, people. I mean, I hate that
Mm-hmm.
term, to be quite frank with you, because
Yeah.
it's such an oversimplification.
Yeah.
Um, but the financial driving forces of putting someone on benzodiazepines, or sometimes even over medicating them with
Mhm.
something like even an antidepressant, you know? So studies have typically shown that psychiatrists tend to under treat with antidepressants and over treat with benzos. And I think the reason for that is because benzos are so effective. And also, if you're worried about losing clientels, unfortunately, if you have them on a benzo, where are they going to go to get a refill?
Mm-hmm.
So there's a component of that that I completely disagree with. When I see a patient for psychiatry, the first visit, I try to keep it around an hour, 45 minutes to an hour. And then when the follow-up happens, I typically will underdose them with an antidepressant, because in my opinion, the role of medications is to make it easier for the person to catch themselves engaging in negative thought or these kind of cycles
Mhm.
that tend to drive them into a tougher position. So
Mm-hmm.
one other thing that people don't realize about benzodiazepines is they do tend to disinhibit people. So not only are you preventing them from developing the coping strategies, but you also tend to disinhibit them into engaging in potentially higher risk-taking behavior at higher doses. And across the board, the longer you are on a benzodiazepine, the rates of dementia do go up the older you get.
Mm.
Oh, really?
So absolutely. So these are things that are not without risk. And I think there's a financial model at play here.
Absolutely.
Yeah. And I'm sure, you guys have seen this all over, right? I mean, you go on Facebook or wherever else, they say, ADHD treatment, we take
Yeah,
insurance.
all these online ones for
Yeah.
$25 and they send you a script.
Exactly, exactly. In my opinion, it's marketed as a convenience thing, but if you can't fix a car in 15 minutes, how can you fix, something as complex as a human brain?
Mm-hmm.
Yeah. I love how transparent you are, Dr. P, about, the system and like the areas that are broken. It's the same reason why treatment, most models are 30 days, because insurance won't pay more than 30 days for treatment.
Mm-hmm.
Usually, sometimes you can get, them to cover 45 days if you really fight for it. And there's that documentation that the patient really needs it.
Yeah.
But really, if we're coming from like the habit forming model and brain repairs, takes 90 days. Everyone's
Yeah.
heard it. It takes
Yeah.
90 days to recreate a habit, because it takes around 10,000 repetitions, which is around 90 days,
Mm-hmm.
and to rewire those neural pathways. So if you're walking into treatment completely emotionally dysregulated because you've had your benzos taken away. You know, it takes time to create those new thought patterns, to have the opportunity to go to group therapy, to show up dysregulated, and to have your community and your peers around you and your therapist to help walk you through those moments. And it doesn't just happen over a week or a day or a few weeks. You know, this is 10.5 years into my own recovery. Like, I'm still, you know, trying to, I feel like, heal my brain from, you know, my addiction. And so that stuff takes time. But it is kind of a broken system where a lot of it is money driven, unfortunately.
Absolutely.
Without a doubt.
And I'm glad you brought up the repairing of the brain, because I wanted to ask Dr. P, and you can speak on this too, but
Yeah.
I was going to gear it towards Dr. P, and then you can come in
Sure.
as well. What happens to the brain when someone's on benzodiazepines for a long time, and like what actually happens? And then when it's taken from them, what happens in the brain as well?
Rewire, yeah.
So if you're below 25, okay, the reason why, let's say, a 12-year-old kid could probably learn a language a lot quicker than I can is because fundamentally they have more neurons than I do. So human beings were born with a lot more neurons than we have as an adult. And all the way till 25, you're destroying the neurons that are not talking to each other, for lack of better words. So people who end up getting exposed to benzos at such an early age tend to have almost, I'm not going to say an aberrant, but they have a different way the brain hardware, for lack of better words, is wired, you know? So you might end up being an individual where you don't have sufficient internal pathways set up to catch yourself from, you know, not having a panic attack, you know, to catch yourself from not just having things exaggerated. A good way to look at the way benzos work, okay, from, you know, from a brain perspective, is they're sort of like the coolant, okay? If you really cool, if you cool the brain down, okay, you're going to be able to get through it. But at the same token, you're not going to function anywhere near as quickly. Mental acuity, you know, your memory, all of those definitely go out the door. And also kind of the executive functioning, the frontal lobe, you know, is tends to be a bit more on autopilot when you have someone on benzodiazepine. So recently they've you know, there's this thing called fMRI where you tag glucose to a radio you know, radiopaque material, and essentially whenever a particular part of your brain ends up getting used, the glucose is cleaved off of this piece that lights up on MRI. So you can tell which part of the brain you're using, and so on and so forth. So typically there's kind of a hypofrontality, which is where you're not using the frontal lobe as much. Now, you know, one of the definitions, for example, of PTSD is kind of this hypervigilance. You know, we're always worried. You're thinking something's going to come at you. You're thinking the world's going to fall apart. You know, a lot of my patients who have PTSD, they have to sit with their back against the corner because, you know, they're worried that, you know, the door's going to be opened and someone's going to walk through. So, you know, if you have a medication that's going to create this, you know, transient hypofrontality, right? This frontal lobe that's not quite as active, then it's going to make them feel a lot more comfortable and societally make them a bit more accepted. You're creating a short-term mental state with benzos. And the key is what happens when the party's done, right? What happens when the benzos are out of your system? Well, you need more. And essentially the brain is like a horse, right? It has to run. It's designed to do as much as possible. You know, you've got people out there who, you know, could, you know, they drink a lot of alcohol and they're highly functional. I'm sure every one of you's known one of those people where, you know, you're like, how are you able to run a company and, you know, there's so much alcohol going through your system?
Yep.
It's because the brain's designed, no matter what, to keep ticking, to keep going, right? So if you're going to introduce something that's going to decrease the amount of functioning of the frontal lobe, the brain will actually build up tolerance to it, and after a while, still be able to do all the amazing things it does, in spite of having the benzo on board. Now, you take the benzo out of the system, you've got a brain that's, you know, redlining, right? And there's kind of this, you know, rebound anxiety that happens, which is much harder to treat. So
Makes it worse than it was before.
Exactly, exactly. When I was doing consult liaison at hospitals, where we're on call for hospitals and the ICU and so on, it's a textbook case where you have individuals where they're acting out, they're sundowning, they're delirious, and the primary team is giving them, Ativan upon Ativan upon Ativan, which is actually making things worse and making them more disinhibited.
It's just
Um,
delaying the inevitable of a withdrawal, right? Just by giving them another benzo. I mean, it kind of delays the
Yeah, I mean,
inevitable.
that's a fair point. That's a fair point. Are you just delaying withdrawal? Well, withdrawal across the board isn't the same for everyone. We do tend to look at opioid and alcohol withdrawal as particularly lethal, but if you have somebody who's got a robust heart, they typically tend to be somewhat okay, with opioid withdrawals as well. But that's not something that you would take a chance on.
Yeah.
So typically when we have a patient that and I'm sure you guys have heard of these cases, they're admitted for like a UTI, let's say they're 65, 70 years old, and they're completely just not themselves. The first rule would be to stop all benzodiazepines because they really do tend to create an aberrant environment for the frontal lobe to function.
Wow.
And, one of the risks of just stopping benzos is having a seizure, and that's where that,
Risk of
um,
death comes in.
Yeah,
yeah, exactly. So that's
Same
why
thing
it's
with
important
alcohol
to
too.
yeah,
exactly. And so that's why it's important to taper off of them.
right.
And sometimes people can do that in an outpatient setting, and sometimes people can't. Maybe they have like medical complications, or maybe they've just been on it for so long that that physical dependency, kind of like what we talked about, has turned into a psychological dependency.
Mhm.
And when it goes to that point, like you need a higher level of care usually
Yeah,
to be able to taper off
And it's longer than
benzos.
30 days.
Yeah, it
Yes.
should be longer than 30 days.
yeah.
Yes.
Well, the interesting thing too is, the go-to for someone having a seizure is actually benzos. So there's some irony there.
Hey,
So if
there
you have
is
a
some
patient,
irony there. It's so
right,
true.
Yeah.
right, so
Mm-hmm.
people with alcohol or benzo use disorder, I mean, they'll, put them on Librium, which is long-acting, benzo, and they'll taper them down, you know. So there are ways of tapering them, but a lot of facilities will end up using benzos to taper them off. So sometimes you have a
Exactly.
patient who comes in and you're, putting them back on a benzo, but then you're slowly taking them off so they don't
Well,
withdraw.
that's
Exactly.
kind of the case with opiates too. I mean, you literally put them on a synthetic opiate to taper them off. I mean, Suboxone's an opiate, isn't it?
The difference with Suboxone compared to other opioids is it's a partial agonist antagonist.
Yeah, it works
You
off
know,
different receptors too.
Yep.
no, it works on
Or
different receptors definitely, but they all work on the mu opioid
the
receptor.
mu. Yep, that's
You
it.
know, and it's still, again, I mean, I think if there's a way that people can use it to make money and hold someone hostage, it seems like they do get away with it. It's almost like methadone 2.0, unfortunately.
Yeah.
Um, with Suboxone clinics and so on. Now, the skill part of that comes down to if you take somebody who's, let's say, on 140 milligrams of morphine per day, or let's say they're using heroin, and you immediately put them on Suboxone, you're going to cause a
Great
pretty significant
withdrawal.
withdrawal. That's right, and that's because it outcompetes the morphine. And kind of the way to look at it is, part of it is a dud.
It has
So
a higher affinity, doesn't it, than regular opiates? So it kind of
it
kicks the
does.
other opiates off.
Yes, right. Now, so a mistake that a lot of people do is to think that Suboxone, buprenorphine, is a synthetic opioid. It's actually an opioid that's derived from a different plant than what heroin's. Right? It's this plant called thebaine, and it's actually naturally occurring, believe it or not.
Wow, I
Um,
did not know that.
yeah,
Mm,
yeah.
I
So
didn't either.
buprenorphine is a thebaine derivative. If you're talking about synthetic opioids, you're thinking of, fentanyl, like things like that. But here's the thing, right? So when it comes down to opioids, there's an evolutionary, interesting side story to that. So you ever wonder why is it that this plant, this opium plant that's in the middle of nowhere, has these chemicals, opium, that are able to connect to our brain, right? It doesn't make any sense. Like, why does our brain
That's
have
a
a
really good
receptor
question.
for this thing, right?
Yeah.
And the reason for that is, at least one theory, is that evolutionarily we have held on to that molecule, and that molecule is near identical to the endorphins and enkephalins that we release right after we've gone through some trauma or when we're going through exercising and so on. So what you're doing is you're taking these opioid mu receptors and you're hyperexposing them to a nth level of an endorphin, you know? So that's one of the reasons why there's really good data out there that low dose naltrexone, you know, which is really what we use for people who have overdosed, and it's a much, much stronger binding agent, actually can simulate endorphins and enkephalins and help people who have chronic pain without um, activating the mu receptor. Now, the interesting thing with buprenorphine, and this goes into the way that I think the FDA has kind of has drawn the line. So a pain doctor like myself, right, can write for a version of Suboxone called a Butrans patch. Okay, so Suboxone is buprenorphine plus naloxone. Okay, what most people don't realize is that naloxone is actually destroyed by our GI tract, and
Yeah,
it's
it's
really
inactive unless you snort it or inject it, correct?
injected. That's right.
Yeah.
That's right. So, you know, people will typically sometimes end up on Subutex, and Subutex is the the buprenorphine without the naloxone attachment to it. And there's people out there who swear that when it's a combination of naloxone and, you know, and buprenorphine, it never works. But the buprenorphine alone, which is Subutex, works. In the pain world, there's actually this thing out there called a Butrans patch, which will deliver micrograms of buprenorphine over the course of a week. It's actually a Schedule 2, and it really does work. So one advantage of putting someone on buprenorphine is that you tend not to have that overblown response where you're making a lot of receptors to the to opioid receptors.
That's why I
to
choose meal
opioids.
preps to go.
And so it kind of keeps it at bay and makes it where you're not building up tolerance to it as much, which is where, you know, Butrans comes in.
At Palms Behavioral Health, we understand the journey to mental wellness. Our dedicated team offers personalized care for adolescents, adults, and seniors. We focus on individualized treatment plans, addressing a wide range of mental health needs. Our evidence-based practices and trauma-informed care ensure sensitive and effective treatment. Palms Behavioral Health, healing minds, empowering lives. Contact us today.
Suboxone.
Sorry to interrupt, but doesn't Suboxone or buprenorphine have a ceiling as well? Like after a certain amount, it doesn't get you any higher or any more euphoric or any less pain. It kind of ceilings at like I think 32 milligrams or 24.
No, theoretically, yes. So theoretically, you've got to remember I mean, every medication has a particular point beyond which it's not really going to be effective, right? You know, there's an ideal dose, and usually there's a couple of milligrams above that you go. Well, let's take, for example, somebody who's had a lower back surgery and they've been put on, you know, morphine, converted to oxycodone, converted to methadone, Baxan oxycodone, and on, right? For someone like that, right, you can actually push, and people do, Suboxone strips or sublingual strips that are ungodly amounts of morphine equivalency, much more than what you would write for on somebody who has an addiction problem, for example. You know, the Butrans patch itself has an upper ceiling, and you can't use Butrans patch for detox. You can't use it for substance abuse. You can only use it for pain. That typically there's not much utility going above 20 micrograms. But that's really more because that's, you know, kind of what the manufacturer has said. And if you go beyond 20 micrograms, you know, insurance is going to approve it. You're not going to be able to get it okay. That's
Back to the
quite different
almighty
compared
dollar.
to Right. And that's quite different compared to like morphine or oxycodone. I mean, you know, the common pill that a lot of people end up using, I think they call them Perk 60s, you know, it's this blue pill, that's synthetic, that's pressed, you know. So you're absolutely right, and there's a higher ceiling for Suboxone, but to be frank with you, it's really a theoretical kind of ceiling. You know, I've seen people breach above it, unfortunately, and you know they just keep going higher and higher. But at the end of the day, you're still dealing with the same issue. You know, what's unique about opioids is if you look at the number of receptors that an average individual will make for an opioid after sufficient amount of exposure. It varies widely. So, I get patients sometimes who come to me and say, look, I'm not an addict. I've never been an addict. My answer is the last time I checked, you've got a human brain. And as long as you have a human brain, you will
You were
start
susceptible to
making
the-
a lot of receptors, right?
yeah.
And the more receptors you make, the less the receptors are occupied by any opioid you give them. So eventually there comes a point where you are going to have to go up. Now, there is no psychiatric indication for opioids. Okay, that doesn't exist. Okay. Addiction is a branch of psychiatry, right? But in some regards, it comes down to safety management, for lack of better words. And in my opinion, people who get, for example, the Sublocade injection and so on, it works and it gets the
And
job
for the
done.
and for the listeners, Sublocade is Suboxone, but in an injection that goes over 30 days, correct?
That's right, once a month, once a month. It's like I'll take that over heroin, right? I mean, and if that's the best that you can do, that's the best you can do. But you never want to lose track of the fact that ultimately you want the individual to be free of the medical field, right? I
Yeah.
mean, the ultimate goal is, you come in, you get taken care of, and you go home. But sometimes there's issues there. I've noticed this a lot with people who are exposed to substances sub 25 years, where it's almost like their brain is aberrantly developed, and without some degree of opiate exposure, they can't get through the day. To give you an idea, if I took, let's say I took an 18-year-old kid who has nothing wrong with them, and I end up putting them on an opioid, they're going to hate it, but let's say I continue the opioid. Okay, in probably 6 months or so, if I were to stop the opioid, they're going to have joint pain. They're going to be just, having pain all over their muscles and so
Hot,
on.
cold sweats.
Yeah, and that's not because they're withdrawing. Okay, that's not because they're withdrawing. That's because there's been kind of this synthetic determination of where your endorphins and enkephalins are coming in. Your body's used to a much higher amount of endorphins and enkephalins, and all of a sudden the amount that your body's putting out is insufficient. So you're going to be in a lot of pain. So people, and on top of that, there's actually something else out there called opioid-induced hyperalgesia, which is a pretty rare case.
Yeah. It's where your pain
Um,
is like at a level 100 after stopping opiates, right?
well, believe it or
Mm.
not just that, your pain is at a level 100 even with exposure to opioids. So even if I bump up the
Wow.
opioids, your pain is at 100. It's almost like there's something that flips in the opioid receptors, such that even if I touch them, I'm talking just on their skin, it gets converted to pain. So
Yep.
that's what they
Wow.
feel. And at that
Interesting.
point, you have to trail them off and hope the receptor levels will go back to normal. Um,
So at the real quick at the tapering spot, Alexis, what is on your side of the industry when
Yeah.
someone's being tapered or in addiction trying to get off of it? Talk us through that part. We got the medical side. Now let's talk about the treatment side or the
Yeah.
recovery side.
So for benzos, for example, in our detox, we use Valium. So we'd start them on a higher dose of Valium, and then each day we would taper them off over the course of, it just is patient dependent, but 5 to 7 days, let's say on average 5 days. Once they get out of detox, because just to be clear, detox is very much just about the physical symptoms. We offer group therapy and we talk about anxiety and we kind of get the ball rolling. But it is really to be like, okay, here's a safe environment to get you off your medications. Let's make sure that you don't have any adverse reactions, any seizures, and then let's move you to residential treatment where kind of the real magic happens, where you learn to emotionally regulate, where we really address that, limbic system that's been dysregulated for so long because you've been using substances to cope, and learn how to function as part of a recovery community in a safe place so that when you are emotionally dysregulated, you don't have your phone right next to you, or you don't have the ability to get in your car and drive down the block to a liquor store, because for the last however many weeks, months, or years, every time
what
you
you've been
feel
doing.
discomfort
Yeah.
inside, you go and you drink wine, you go and you drink liquor, you drink, you use substances to change the way that you feel. You either want to numb out, you want to escape, and that's how you've been living your life, and so you go into residential treatment to learn to live a new way of life, and that is without those substances, and it takes a while to adapt to that new way of life. But when you have professionals in a community giving you that template, like, here, we have used this and our lives are tremendously better. Speaking from experience, I have a template to live a life of recovery, and 10 and a half years later, my life has blossomed in ways that I never could have imagined. Let me show you how you can do this too. Let me show you how you can be part of a community and your life can evolve. You don't have to be, a slave to this drug and this substance every day of your life, because when you're in addiction, like, that is all you think about.
Yeah, that's all you
It is
think about. That's
all
all
you
you
think
care
about.
about.
And you want to so badly care about something else, but your mental obsession has such a grip on you that you cannot. And so really you get to step into residential treatment. And people are like, it seems daunting, but God, I would love to go away, even now at 10 and a half years, for 30 days to go work on myself. You know what I mean? To be able to sit with a bunch of women and talk about, like, ways in which we can grow together and, just become a better version of myself. So it really is such a gift if you're given the opportunity, if you get the opportunity to get to go to treatment. So that's kind of where we, take it as far as, tapering down the medications, going to residential treatment. And then after residential treatment, there's other levels of care like partial hospitalization, which is kind of a step in between residential and intensive outpatient. So in residential treatment, you're sleeping there, right? You are staying there in a room, you're waking up, you have a schedule, you're going through the schedule, and you're staying there anywhere from 21 to 90 days. Once you step down to PHP, we're like, okay, here's your laptop, here's your phone, here, you're getting more responsibilities back. Because what we see in places that I've worked, that have allowed electronics and phones versus places that maybe take those away, or that do take them away during treatment. I think we can all say that we escape with our phones, right? If I want to avoid something, it's really easy for me to get on my phone and jump on social media to avoid the way that I feel. And so if I have this as a crutch in treatment, then what real work do I have to do? I don't. I don't actually have to walk through that discomfort and work on myself, because I have this to keep me disconnected from my peers and to keep me disconnected from myself. So
how ironic is that? I don't mean to cut you off, but how ironic is you want to be disconnected, but you hop on a device like
To
social
disconnect.
media that puts you connected to these people that you're trying to disconnect from. It's
technology is, yes. It's such a, it's when somebody figures out how to have a good balance with my phone and social media, you guys let me know your trick, because I'm either on social media or it's deleted off my phone. There's like no in between, because I'm like naturally one of those like extremists. So everything's extreme. So I have to like take things away from myself.
And again, you're now with Infinite Recovery, correct?
Yes, I'm with Infinite Recovery. Yeah, we're located in Austin.
Awesome.
Yep. And we have every level of care: detox, residential, PHP, and then IOP. So outpatient is, the natural progression for someone to truly, you can be successful in any level, right? You don't even have to go to treatment. You could essentially just start working some type of program, working with a therapist. But the best outcomes, the more successful patients in recovery, or more success, you're more likely to have success if you go to treatment, long-term treatment, and then gradually have that step down process. And attend IOP, which is maybe a few days a week for a few hours. So you're still part of the community, but you're slowly gaining more responsibilities back, because, we definitely need that in early sobriety.
Yeah, absolutely. I agree with that. And you mentioned something about the mental obsession. So back to the medical side, Dr. P, what causes the mental obsession? What causes you to just only think and obsess about getting the next drug or getting your next dose? What happens in the brain there?
So, there's a reward pathway, right? And you do something that sort of allows you to get a little bit of dopamine, and that you go back and you try to get more dopamine. This is kind of a fundamental driving force for a lot of what we do. Now, interestingly, when it comes down to what causes individuals to get driven most by dopamine, is when you have what's called variable rewards. Okay, so variable rewards are essentially where, and if you go to any casino, they have absolutely taken that to the nth level. you
Mm-hmm.
know so it's not that you're going to get a dopamine rush every time you press the button, right? Most people make the mistake of thinking that if you were to give, let's say, a rat a dopamine rush every time it presses the button, then the rat's going to just keep pressing the button. No, eventually it builds up tolerance to the dopamine and it'll walk away from the button. What you do is every time the rat presses the button, you end up giving it a dopamine rush that is variable, but it knows it's not going to get the dopamine rush if it does not push the button. So that's typically how you're able to modify behavior. Now, when it comes to getting euphoric off of psychotropic medications, it's not possible to keep getting the same amount of euphoria over and over and over again. And typically people who've abused for a while, or bad exposure to it, will say that they're always chasing after the initial high, for example. you
Yeah,
know
that first high, that first feeling.
Exactly. And so what ends up happening is you start taking higher and higher risks in the possibility that you're going to get that dopamine rush. Okay. And it takes a lot of mental training, in my opinion, to get the same degree of dopamine rush, doing day-to-day activities. Right. Like, and if I have a good day and I've taken care of a lot of patients and, I'm kind of proud of what we've done, I feel great.
Yeah.
But frankly, it's not going to come anywhere near the amount of dopamine rush that someone would have if they were to have been exposed to heroin for the first time. So they go back in and they try again. Sometimes they end up getting heroin that's not as potent, or sometimes it's more potent. So it becomes the perfect variable reward pathway that keeps you chasing after, almost novelty seeking behavior starts to manifest, that's in concert with trying out the substance.
Mm-hmm.
You know, there's also another component. I've certainly met a lot of individuals who have psychiatric illness that are not being managed well. This would be someone, let's say, for example, who has PTSD and ends up having heroin dependency. So one of the first things that I'll ask a patient if I'm evaluating them is, what's your drug of choice? A person who's always wanted or who's always been attracted to uppers tends to be, in my opinion, psychologically wired differently than somebody who's always chasing after downers. And there's a component of, let's say they're trying to treat their anxiety or they're trying to treat their depression, but you take that with the variable reward pathway, you're always going to take on higher risk. So it's almost like people invest in stock markets, right? You could always get contracts, you could always get calls or puts, and you may win, you may not win.
Yeah.
Or you could take the Berkshire Hathaway approach and look at your 4% return and be happy,
You
right?
talk about another kind of addiction, the stock
Right.
market gambling.
Well, I know
Right.
I don't mean to cut you off, Doc, but we're running short on time, and I just want to say that this has been one of the most informative roundtables that we've had on the podcast.
Yeah, no
since the
kidding.
inception of the podcast. So I just want to give kudos to both of you, you, Dr. P, and Alexis, for joining the show today, because the knowledge and the outlook that you two have respectively brought to the show cannot be duplicated, and I just want to say thank you.
Absolutely. It's unmatched
Yeah.
being able to have both sides of the table and talking about the medical and the mental side of it. I think it was great.
And so, Dr. P, for everyone that doesn't know, you are the founder of ATX 360 Pain Management, correct?
That's right. Yeah, we're essentially the only facility in Austin that does a hybrid psychiatry and pain management. So we take care of people's psychiatric and pain management needs under one roof.
Oh,
Come in with chronic pain, we'll help you out with your depression from chronic pain, so on. And we also help with addiction in every way we can.
I love it. And
Glad to be
Dr. P
here.
has been on the show before, so you can go check out his episode. I think it recently aired a couple of weeks ago. Alexis, you are now with Infinite Recovery, and you have been a past guest as well. So
Yep.
kind of plug Infinite Recovery.
Yeah. Well, first off, I can back up Dr. P. He is an amazing doctor. So we've worked together before at my last 2 facilities ago, and his bedside manners, the way he connects with his patients is beautiful. So I have a lot of
Thanks,
respect for you,
Alexis.
Dr. P.
Yeah, I appreciate that.
Yeah, I'm with Infinite Recovery now. So we're down in the Austin, Texas area. And like I said, we provide all levels of care for individuals struggling with substance abuse. We are a 12-step immersive gender-specific program with a very good balance of a clinical side, very trauma-informed programming. So if anybody is needing help, I think you guys post our contact information after the
Definitely.
podcast, and you can always reach out to me. I'm here to help, and not just, if we're not a good fit, or if you're not ready for inpatient, I'm also just here as a woman in recovery that wants to help you and get you connected to and meet you kind of where you're at. So I'm just happy to help in any way I can.
I can vouch for that because Alexis, you're the one that introduced us to Dr. P. So
Yeah.
the connecting of
Yep.
people is what
Absolutely.
Alexis does. So yes, thank you both
Yep.
for joining the show this week.
Yeah, and we'll put both of their contact information for their clinics, facilities, and ways to get a hold of them on the show as well. So that'll be out there.
Fantastic,
Perfect.
guys. Well, you're welcome back anytime, and thank you for joining the show again.
Thank you guys very much.
Bye. Thank you, everyone.
Thank you.
Like, we weren't supposed to come up with something this clean. Like, something happened.